Hello everyone. So today we are going to talk about functional assessment of the diaphragm. My name is Dr. Mustafizur Rahman, consultant anesthesia and critical care. So without further delay, let's get started into the slides. So we will divide the sections or learning objectives into four headings: anatomy and physiology, its causes of dysfunction of the diaphragm, its assessment by ultrasound, and its relevance in ICU and perioperative care, right? So why diaphragm matters? Because it is the primary muscle of respiration, and its dysfunction leads to weaning failure. Often ICU acquired weakness is due to diaphragmatic weakness also. So in anatomy, as we all know, it is a dome-shaped muscular tendinous structure placed between thoracic and abdominal cavity, which is innervated by the cervical, uh, you mean phrenic nerve, by cervical roots 4, and 5. Arterial supply is by pericardiophrenic and musculophrenic artery. So you can see in the diagram, it's a beautiful diagram showing the central tendinous part and peripheral muscular part along with its uh, openings through which inferior vena cava, esophagus, vagus nerve, and aorta will aorta is passed along with its two crosses of the diaphragm. Here is a beautiful image also. You can see the dome shaped structure. So coming back to physiology. So primary muscle of respiration is diaphragm, and it accounts for 70% of tidal volume during quiet breathing. It descends during inspiration, while creating a negative intrathoracic pressure, which will further leads to increased venous return to the right side of the heart via IVC. It also control expiratory airflow for our speech and singing. So what is the muscle fiber composition of the diaphragm? It's type 1 and type 2 fiber. It is the type 1 fiber which is highly fatigue resistant, and it is for continuous activity of the diaphragm, and it's almost consists of more than 55 to 60% of the fibers. And type 2 fibers are the fast twitch fibers for exercises and forceful breathing. And what about its neural control? That means nerve supply. It is supplied by autonomic control is by medullary respiratory center, and voluntary control, as you all know, by cerebral cortex. Afferent inputs from blood, which stimulates the chemoreceptors. For example, pH of the blood, partial pressure of oxygen in the blood, partial pressure of carbon dioxide in the blood, which stimulates the respiratory center for inspiration and expiration. Also, the mechanoreceptors in the lung. So, what is diaphragmatic dysfunction mainly? It may be due to unilateral dysfunction or bilateral dysfunction. It may be partial or complete loss of function of the diaphragm. So, what are the causes? Prolonged mechanical ventilation, sepsis, dyselectrolytemia, neuromuscular diseases, and one of the most common cause is interscalene block in regional anesthesia. Okay. So, what are the clinical clues or features which patient presents to you? Dyspnea, paradoxical breathing, as you can observe in the patient, failed SBT frequently in a patient of prolonged mechanical ventilation. You should suspect diaphragmatic dysfunction also. So why now ultrasound? Why USG? Because it is a non-invasive method. It can be do multiple times, repeatable, and it is less time consuming. Right? You can do it in bedside. So what are the methods to assess the diaphragmatic dysfunction? There are two methods. One is excursion technique. One is by measuring thickness of the diaphragm and thickening fraction. Okay, now coming back to its first technique, that is excursion technique. So you can choose a ultrasound probe. It may be a high frequency linear probe or a phased area probe. In the subcostal view, subcostal area, you put it in the mid clavicular line and put the M mode on. Here is a beautiful video describing the excursion technique and the measurement. You can see here. Okay, here M mode is on and you can see the wavy appearance of the diaphragm. We froze the image and taken the measurements. Here you will see in the video also beautifully. Yes, the sample gate is placed at the level of diaphragm. So here the measurements are there from the peak to trough. Okay, here it is 2.6 centimeter. Okay, so what is its normal value of excursion? So here is a chart. You can take a snapshot here for remembering. In normal quiet breathing, it should be more than 1.1 centimeter, and during deep breathing, it should be more than 4 centimeter. Any measurements less than 1.1 centimeter and less than 4 centimeter leads to diaphragmatic dysfunction. Okay, now coming back to the second technique, that is measurement of the thickening fraction of the diaphragm. Right, so patient position should be supine, and you can choose the high frequency linear probe. In the mid axillary line, in the zone of apposition, the probe should be put. So what is your zone of apposition? It is the area where the diaphragm meets the ribs. Now this is a formula where in the M mode we have taken the inspiratory thickness and the expiratory thickness of the diaphragm and put in this formula. Okay, what are the interpretations? Any thickening fraction more than 20% is normal, and anything less than 20% is having diaphragmatic dysfunction. Okay, so what are its implications in weaning? So it predicts the extubation success and guides the spontaneous breathing trial. Okay, so there are some disadvantages of the ultrasound assessment of these two techniques. Like in large obese patient, in a ventilator dependent patient, it is very difficult to assess the abdomen by putting the probe in the large abdomen. Okay, these two are the disadvantages, or you can say the pitfalls of assessing the diaphragm. So here is a beautiful video of your thickening fraction. You can listen to it also.
Hello everyone. So today I am going to talk about measurement of diaphragmatic thickening fraction. So first of all, the probe should be high frequency linear probe. The patient position should be supine position, and the line of examination should be in the mid axillary line in the zone of apposition. Zone of apposition means where the diaphragm meets the ribs. So by holding the probe gently, you can see in the image screen that a hypoechoic structure is sandwiched between two hyperechoic structure moving with a respiration. That is your diaphragm. So our next step is to put the M mode on. As you can see already M mode is on, and I have placed the sample gate at the level of diaphragm. So we will take all the measurements by freezing the M mode. So here is the measurements. I have already frozen the image for you. The measurements are end inspiratory thickness and end expiratory thickness by a formula shown in the screen. That is your end inspiratory thickness minus expiratory thickness divided by end expiratory thickness in percentage. So any thickening fraction more than 20% should be considered as.
Okay, so you have seen the video of the measurement of thickening fraction of the diaphragm. Now what are its importance in ICU and perioperative care? So identification of failure of extubation process or weaning failure or spontaneous breathing trial failure in a long-term ventilated patient through ET tube in ICU. If you uh, if you are getting repeatedly SBT failure, then you should suspect the diaphragmatic dysfunction. And just by mere putting the ultrasound, by these two techniques, you can identify the diaphragmatic problem. Okay, so this is the importance in ICU and perioperative care. So our take home message will be, it is the most common and undiagnosed problem of the ICU, which can lead to spontaneous breathing trial failure or weaning failure. And of course, ultrasound is the gold standard to diagnose it. Thank you, everyone. Thank you for being listening patiently.